Hey guys, welcome to Mini Med School, where today we're gonna talk about this angiotensin receptor blockers. In my previous video, I have talked about the angiotensin converting enzyme inhibitors, and this video we will deal with this angiotensin receptor blockers. So if you haven't yet subscribed to the channel, guys, please do that because you're gonna get amazing stuff in this channel. Okay, let us get into it. What is this ARB or angiotensin receptor blockers? So, when we have seen this flow chart earlier, uh, earlier video where we have talked about the ACE inhibitors, we have blocked the ACE so that there is no angiotensin 2, no receptor, no aldosterone, nothing of this sort. Now, what made the difference when I block this? Similar, no? There is no function, there is no vasoconstriction, no aldosterone. The same function happens. Yes, ACE inhibitors as well as the ARBs, they have the similar function. But why we have to use them and why not them? We use both of them, but there are some conditions and there are some advantages of ARBs over ACEs which we have to know so that we can use them clinically. So what are all those uses is, firstly, we told this ACE, it is responsible for metabolism of the bradykinin. So if you inhibit this, bradykinin effects are also seen. But when you inhibit this, there is no effect of or no thing we need to talk about this bradykinin. So there is no increase in the bradykinin if you directly inhibit the receptor. As a result, what happened? The first two adverse effects, CA, there is no dry cough and there is no angioedema. Therefore, in people who are on the ACE inhibitors, if they have very damaging type of scenario, like if they have lots of cough, then you need to stop them and you should start ARBs. And mostly, these ARBs, they end with Saturns. So Saturns, we mostly talk about the selective angiotensin receptor 1 blockers. So there are two types of receptors, angiotensin receptors 1 and angiotensin receptors 2. So what ARBs we're going to talk here is they are selective AT1 receptors blockers that which include the sartans. So sartans, the losartan, which include losartan, telmisartan, valsartan, irbesartan, and so many. So all those that end with sartans, we consider them as ARBs, that is selective angiotensin 1 receptor blockers. And this losartan is competitively antagonist of the thromboxane A2. Thromboxane A2, which will inhibit the platelet aggregation. This is another advantage so that we can use ARBs over ACE inhibitors. And one of its metabolite, what happens is it will reduces the cyclooxygenase enzyme and decreases the PG, prostaglandin synthesis. And these ARBs, they also reduce the blood pressure, but together with that, they also reduce the proliferation of the tunica intima of the artery. So what are all the uses which ARBs have over the ACEs is, one, there is no bradykinin, no cough, no angioedema, and losartan, which will inhibit the thromboxane A2, which will inhibit the platelet aggregation, and one of its metabolite decreases the cyclooxygenase enzyme, which will decreases the prostaglandin synthesis, and it also reduces the blood pressure, which together which also reduces the proliferation of the tunica intima of the artery. So why one more advantage is if we have inhibited this ACE, there is no angiotensin 2, but there are some other ways also which can produce this angiotensin 2, and this pathway may literally happen at somewhere in the body, but when you inhibit the things at the receptor site, there is no chance of these actions happening again, no matter from which pathway the angiotensin 2 come. Okay, now let us talk about the pharmacokinetics. Pharmacokinetics of this ARBs that can be taken orally whose bioavailability is less than 50%. And when you talk about the losartan, it is metabolized in the liver and produces its metabolite, which reduces the cyclic oxygenase activity and decreases the prostaglandin synthesis, which is dependent over the COX enzyme, and it have the plasma protein binding ability and is excreted via the gut, not by the kidney, so via the gut. Now, what are all the adverse effects? So if you have seen the previous video where we have talked about the pneumonic captopril, except the first two, CA, P, so these are the side effects of the ARBs. Other than the first two, rest of the things will be same. That is, sorry, not even P, just topril. So taste alteration will be there. Orthostatic hypotension will be there, and you'll be contraindicated in the pregnancy, contraindicated in the bilateral renal artery stenosis, and these known to reduce the risk of the diabetic nephropathy. Now coming to the uses. So hypertensive drugs, they are the alternatives used in hypertension as an alternative of the AC inhibitors in people who get lots of cough and the angioedema, and they can be combined with the diuretics. So when we talked in the angiotensin and converting enzyme inhibitors, they should not be combined with the diuretics, but here we have no problem, you can combine it with the diuretics. And the cardiac failure, so in cardiac failure also there are the alternatives for the angiotensin converting enzyme inhibitors in patients who are poorly tolerant to them. Next, AC inhibitors are usually considered to be the first line drugs for the cardiac failure, but ARBs are given to the patient who are not tolerant for them. And in diabetes mellitus and the kidney dysfunctioning, these ARBs act as a renoprotective function, and they also prevent the stroke, and they're also used in atrial fibrillation, mainly the irbesartan, which will maintain the cardiac rhythm, and is also used in the portal hypertension and the liver cirrhosis. In both of this condition, losartan will be safe and effective. Okay guys, that's it with the video. Hope you found it a better way of understanding. Thank you for watching. If you like and share, and do not forget to subscribe to the channel for wonderful content. Thank you.